my name is Ajai Chari. I'm a professor of clinical medicine and the director of the Myeloma Program at the University of California, San Francisco. And it's my pleasure to be presenting at this year's ASH some results about the MonumenTAL-1 study. So MonumenTAL-1 was the study that led to the accelerated approval of talquetamab, which is the first GPRC5D targeting therapy in myeloma. And the background to this year's ASH abstract is those results from MonumenTAL-1 showed in a heavily treated population a response rate of over 70%, a PFS of 14 months for the 0.8 milligram per kilogram every 2-week dosing. And encouragingly, we didn't see a lot of infectious complications, in particular, not a lot of COVID deaths, in only 2 in over 350 patients. And I think the other interesting things that those progression-free survival for high risk and standard risk are nearly superimposable, which is something we almost never see because typically high-risk patients respond, but they tend not to be lasting. So those are kind of the favorable features of this agent. But the drug also has some unique on-target off-tumor effects, and those include dysgeusia, loss of taste, and also palmar-plantar peeling, other kinds of rashes of the body, and then also nail changes. I would say of those, the one that can be the most challenging for patients, and then therefore the treatment team, is the taste. And so what we realized was that the median time to response with talquetamab is about 1 month, and the median time to best response is about 3 months. So in this study, what we wanted to investigate is, can we back off on the dosing and schedule of the drug to mitigate those side effects? So that was the premise of this study. And the way we went about it is, first we looked at retrospectively about 50 patients coming from all 3 cohorts, which includes the weekly 0.4 milligram per kilogram, the every 2 week 0.8, and then also either dosing but in the prior T-cell redirection. So in those 50 patients, what we saw was that the response in PFS and duration of response did not seem to be adversely affected. But the problem with doing retrospective work is that it can be a little bit circular. People who do better, right? So the only patients that had dose reductions were likely those that the physicians and patients felt comfortable. And so we wanted to do this in a separate prospective cohort to make sure that this really didn't have any impact on the disease control. And so there was a separate cohort, about 19 patients, half of whom approximately had a reduction in the dosing. So we went from 0.8 milligram per kilogram to 0.4 milligrams per kilogram every 2 weeks. And then another group went from 0.8 every 2 weeks to 0.8 once a month. So either the dose or the schedule. And what we found in these 19 patients is the same thing. No drop in response, PFS, duration of response seems comparable with the overall cohort. So that was encouraging to see. But we also saw a hint that some of these toxicities got better. The oral toxicities, the skin toxicities, the nail trending favorably. Weight loss, we didn't see a definitive trend. But I think this is really encouraging data. Now, the other thing we found as we were doing this is 2 other interesting things. One is that it turns out this may be one of the first drugs in myeloma where the adverse events may correlate with the efficacy. So we know, for example, in solid tumors that rashes can correlate with some drug response, but we don't really have that in myeloma. And what we found in this study was that if patients had particularly taste or skin changes in the first 3 months, there was actually a 20% higher likelihood of getting a response to the drug. Now, I want to be cautious that people don't misinterpret that. The drug is very active, 70+%. These adverse events are quite common. So it doesn't mean that if somebody doesn't have these side effects that they won't respond. But if you do have these, it may be a biomarker that you're more sensitive to the drug and responding myeloma-wise, right? And that may be why we're able to reduce the drug without any compromise. The other interesting thing we found from this study was that when you back off on the dosing and schedule in this prospective cohort, there was also some evidence that there was less T-cell exhaustion, which is good and maybe bodes well for subsequent therapies and duration of remission. So I think this is really encouraging data, and we're probably looking at it in other bispecifics as well, this modulation. So I would say the take-home message for this study is this is a very active drug with high response rates, durable and deep remissions. And some people think that the dose initially maybe was not right, but no, this was initially studied in heavily treated patients, many of who had exhausted all their therapies. And in that population, we need this RP2D dose to get that efficacy. But we also have learned that when you back off on the dose intensity, you can maintain that response without compromise and then mitigate those side effects. So I hope this is important. I hope people will take this message that you can get the benefit without having as much side effects, and more people will be able to benefit from this therapy. And future studies are doing this exactly planned dose reduction at the time of response. So it's a great way of managing this. And also I would highlight that future studies, we're going to try to understand this more, because let's face it, dysgeusia is not a topic that myeloma docs know a lot about. So future studies are going to look at more granular understanding of taste, trying to distinguish between bitter, sour, salty, sweet, trying to get a better sense of severity, because right now the CTC criteria are just grade 1 and 2. But until we get that, we have this dosing strategy.